This is Pratima and you are watching Planet Physiology. Today we shall study second part of mechanism of urine formation, that is role of loop of Henle, distal convoluted tubules and cortical and medullary collecting ducts. In previous part we have seen that proximal convoluted tubules reabsorb 100% of filtered glucose and amino acid, 90% of the bicarbonates and 65% of sodium and water. As a result, filtrate that leaves the proximal tubule is isoosmotic, that is, its osmolarity is same as that of plasma, which is 300 milliosmoles per liter. Now, the filtrate mainly has metabolic waste products and some electrolytes. This filtrate now enters the loop of Henle. Loop of Henle has thin descending, thin ascending and thick ascending segment. If you remember, there are two types of nephrons, cortical and juxtamedullary. As cortical nephrons are mainly involved in urine formation, today we shall study only their functions. Cortical nephrons have short loop of Henle and they lack thin ascending limb of loop of Henle. Let's start with the thin descending limb of loop of Henle. It is lined by flat squamous type of cells. These cells lack brush border and possess few mitochondria, indicating their low metabolic activities. This segment is permeable to water. Epithelial cells possess aquaporin 1 water channels in their apical as well as basolateral surfaces, allowing rapid movement of water along the gradient. Descending segment reabsorbs about 15 to 20% of the filtered water load. This segment is moderately permeable to solutes and is concerned with passive reabsorption of solutes, but it is very negligible. Since this segment mainly reabsorbs water but very little solutes, filtrate becomes concentrated as it moves towards the tip of loop of Henle. Now coming to the thick ascending limb of loop of Henle, epithelial cells lining thick ascending limb are thicker, they lack brush border and possess more mitochondria, indicating their role in active solute reabsorption. Like proximal tubules, these cells also possess sodium-potassium pumps on their basolateral surface, which create concentration gradient for sodium. This gradient facilitates sodium influx from luminal border. Luminal border, that is the apical border of the cells, possess NKCC cotransporters. NKCC stands for 1 sodium, 1 potassium and 2 chloride transporter. Thus, sodium ions carry potassium and chloride along with them. Once within the cell, sodium are pumped out by sodium-potassium pumps from the basolateral surface. Chloride ions diffuse out via voltage-gated chloride channels called CLCKB or Bartin channels. Potassium ions are also transported into the interstitium via ROMK channels. It stands for renal outer medullary potassium channels. These are magnesium and ATP dependent transporters. Small quantities of potassium also leaks back into the lumen, creating positivity of about plus 8 millivolts inside the lumen. This positive potential facilitates reabsorption of magnesium and calcium via paracellular route. Apical surface of epithelial cells also has sodium-hydrogen exchangers. So they absorb sodium in exchange for hydrogen ions. Thus, they also secrete hydrogen ions. Thus, thick ascending limb of loop of Henle reabsorbs about 25% of the solutes, but at the same time it is impermeable to water. Hence, filtrate gets diluted or becomes hypoosmolar. Solute reabsorption in this part plays significant role in formation of concentrated urine. Let us see some clinical aspects related to loop of Henle. Drugs like furosemide or Lasix block NKCC transporters and prevent solute reabsorption by thick ascending limb of loop of Henle. These drugs are called as loop diuretics because They prevent solute absorption, leading to their excretion. As these are osmotically active solutes, they also excrete a lot of water, causing diuresis. Another clinical importance associated with this segment is Barter's syndrome. It is a rare inherited disease characterized by hypokalemia, alkalosis, polyuria, and polydipsia, leading to dehydration. Hypovolemia raises renin secretion, but blood pressure may be normal or low. Type 1 Bartter syndrome is due to mutation of NKCC2 cotransporters, and type 2 is due to mutation of ROMK transporters. Both these are neonatal subtypes, while type 3 Bartter syndrome is caused due to mutation of chloride channels and is classical form of Bartter syndrome. So let us quickly summarize role of loop of Henle. Thin descending limb is permeable to water due to presence of aquaporin 1 water channels. It reabsorbs about 15 to 20% of the filtered load of water. Sodium, potassium and chloride are co-transported out of thick ascending segment, while magnesium and calcium are reabsorbed by paracellular route. This segment is totally impermeable to water and hence filtrate gets diluted. About 25% of the solutes are reabsorbed by loop of Henle's thick ascending segment. Now coming to the distal convoluted tubules. Initial part of distal convoluted tubules runs between the afferent and the efferent arterioles and is modified to form juxtaglomerular apparatus. It plays important role in regulation of GFR and renal blood flow. Distal tubules is then divided into two parts, early and late. Early part of DCT is functionally similar to that of thick ascending limb of loop of Henle. So epithelial cells possess few microvilli, but there is no distinct brush border. This part of DCT continues to reabsorb solutes, but is impermeable to water. As a result, filtrate becomes hypotonic and hence this segment is called as diluting segment. DCT becomes permeable to water in presence of antidiuretic hormone, thus is involved in facultative reabsorption of water. Distal tubule is also impermeable to urea. Luminal surface of the cells has sodium chloride cotransporters called as NCC, which move sodium and chloride into the cell. Sodium is then pumped out into the interstitial fluid by sodium-potassium pump. Chloride ions diffuse into the interstitium via chloride channels. NCC are inhibited by thiazide diuretics used in treatment of hypertension as well as cardiac failure. Basolateral surface of the cells also has sodium-calcium exchangers. They transport sodium into the cell and calcium into the interstitial fluid. This creates concentration gradient for calcium, which facilitates calcium reabsorption from the tubular lumen. Thus, early distal tubule reabsorbs about 5% of the filtered solutes, mainly sodium. But note that it is impermeable to urea. Late distal tubule has functional similarity with that of collecting ducts. Hence, we shall consider both these segments together. Epithelium lining this segment is cuboidal and the cells are of two types: light staining principal cells or P cells and dark staining intercalated or I cells. Principal cells predominate and possess fewer cell organelles and occasional microvilli, but intercalated cells possess more microvilli and cell organelles. P cells, that is the principal cells, are involved in sodium reabsorption and vasopressin stimulated water reabsorption. Let us study how. Like previous segments, these cells also possess sodium-potassium pumps on their basolateral surface. They create concentration gradient for sodium, which facilitates sodium influx from the luminal surface via ENaC channels. ENaC is nothing but epithelial sodium channels. As positively charged sodium ions enter the cell, electrical gradient is created across the luminal surface. This favors secretion of potassium along its electrochemical gradient into the filtrate. Thus, principal cells are mainly involved in reabsorption of sodium and secretion of potassium ions. Aldosterone increases the number of enacs in the luminal surface and also stimulate activity of sodium-potassium pumps on the basolateral side. Thus, it increases sodium reabsorption and potassium secretion. Drugs like amiloride inhibit ENaC and prevent sodium reabsorption, leading to diuresis. Spironolactone antagonizes the effect of aldosterone by inhibiting activity of sodium-potassium pump. As these drugs decrease sodium reabsorption and hence decrease potassium secretion, they are also called as potassium-sparing diuretics. Now let us study water reabsorption by principal cells. Normally, these are not permeable to water, but they become permeable in presence of antidiuretic hormone. These cells store aquaporin 2 water channels in the vesicles. When ADH is released from posterior pituitary, it binds with V2 receptors on the basolateral surface of the epithelial cells and activate adenyl cyclase. This in turn increases intracellular cyclic AMP concentration, causing vesicles to fuse with the luminal border. Thus, there is insertion of aquaporins into the luminal membrane. Now membrane becomes permeable to water and water moves through these aquaporins into the cell and then into the interstitium. In presence of ADH, late distal tubules and the cortical collecting ducts can absorb about 10% of the filtered water load. Absence of ADH secretion causes pituitary diabetes, while mutations of V2 receptors or aquaporin 2 water channels lead to nephrogenic diabetes insipidus. In both the conditions, cortical ducts fail to reabsorb water, causing formation of large quantity of urine. Urine volume increases to 23 liters per day with osmolarity of 30 milliosmoles per liter. This manifests as polyuria and polydipsia, leading to dehydration. Now the second type of epithelial cells in the late distal tubules and the cortical collecting ducts are intercalated cells or eye cells. They play important role in acid-base regulation. Within intercalated cells, carbon dioxide combines with water to form carbonic acid. And this reaction is facilitated by the presence of enzyme carbonic anhydrase. Carbonic acid then dissociates into hydrogen ion and bicarbonate ion. Hydrogen ions are pumped out into the lumen by primary active transport process. Luminal border has hydrogen ATPases as well as hydrogen potassium antiporters. Bicarbonate ions are transported into the interstitium in exchange for chloride with the help of band 3 protein. The chloride ions then diffuse into the lumen, forming hydrochloric acid inside the lumen. Thus, for each hydrogen ion secreted, intercalated cells produce and reabsorb one bicarbonate and plays important role in acid-base regulation. Even though this process of hydrogen secretion is similar to that of proximal tubule, the major difference lies in the type of hydrogen transporter. In proximal tubule, it is sodium hydrogen antiport, which was secondary active transport. But in intercalated cells, it is primary active transport. This ATPase can work even against the concentration gradient of 1000:1. So it is more powerful and cause maximal acidification of urine with pH of 4.5. Aldosterone stimulates activity of hydrogen pumps and also causes insertion of hydrogen ATPase by translocating the vesicles containing these pumps into the luminal membrane. Intercalated cells not only reabsorb bicarbonate but also potassium ions. It will be nice to know that intercalated cells are of three types. The process we have just studied is seen in alpha intercalated cells, that is hydrogen secretion and bicarbonate reabsorption via band 3 protein. The second variety of intercalated cells is beta intercalated cells. These cells secrete bicarbonate ions via pendrin transporters into the lumen and reabsorb hydrogen ions. Thus, they are active during alkalosis. The third variety is non-alpha, non-beta intercalated cells. They secrete both acids as well as bicarbonates. Now the last segment of the nephron, medullary collecting ducts. These are the final sites for urine formation. They determine final urine volume, its composition and osmolarity. This segment is also same like that of cortical collecting ducts, which is permeable to water only in presence of antidiuretic hormone. It can reabsorb about 5% of the water in presence of ADH. It also secretes hydrogen ions by primary active transport process. The important difference in the cortical and the medullary collecting duct is this segment is permeable to urea, and urea reabsorption plays important role in formation of concentrated urine. As we have reached the end of the topic, let us have a quick look at the important points. Descending limb of Loop of Henle reabsorbs about 20% of the water. Ascending limb is impermeable to water but actively reabsorbs 25% of the solutes. Early distal tubule is diluting segment as it continues to reabsorb solutes but not water. It reabsorbs 5% of the solutes. Late distal tubules and the collecting ducts are functionally similar, possesses two types of cells. Principal cells reabsorb sodium and secrete potassium. They can also reabsorb about 10% of the water in presence of ADH. Intercalated cells secrete hydrogen ions by primary active process and reabsorb bicarbonate. Medullary collecting ducts also have same properties as that of cortical ducts, but they are permeable to urea as well. The medullary ducts, they decide final urine volume and composition. Each of these segments, they have specific transporters which can be blocked by specific diuretics or stimulated by certain hormones and drugs. Water reabsorption from distal tubules, collecting ducts and the medullary ducts is called as facultative water reabsorption. That's all about the role of various segments of the renal tubules in urine formation. In the next part, we shall discuss regulation of tubular reabsorption and secretion processes. Thank you for watching and see you in the next video. If you enjoy my presentations, press the like button and share it with your friends. For more such videos, subscribe my channel and click the bell icon. Thank you for watching and see you in the next video.